Okay, now we need to know what is the symptoms which if the patient have noticed, or the healthcare team, either physician or pharmacist or whatever, if they notice these symptoms, they need to advise the patient to stop fasting immediately. First principle related to the glycemic. Of course, as we know, there is 4 risk for the fasting people, or the patient who's fasting: hypoglycemia or hyperglycemia, or thrombosis or dehydration. So 2 of these 4 related to the glucose level, and 2 related to the hydration status of the patient. Related to the glucose level, either hypoglycemia or hyperglycemia. If the blood glucose less than 70 milligram per deciliter, which means 3.9 millimole per liter, or the serum glucose level more than 300 milligram per deciliter, which means 16.6 millimole per liter, at this time the patient must stop fasting immediately. Why? Because in case of hypoglycemia, blood glucose less than 70, the patient, if he continue fasting, maybe this lead to coma and can cause cardiac arrest later on. So I need to intervene immediately and giving the patient oral dextrose if it is applicable, or IV, IV dextrose 50, to overcome this hypoglycemic condition. And this is very critical, and for your knowledge, that hypoglycemia, one of the common causes of death for ICU patients, and it's more critical than hyperglycemia. And if hyperglycemia, the blood glucose level more than 300, the patient maybe got risk of diabetic ketoacidosis, and also this is a serious condition which can lead the patient to be admitted at the hospital. So also I need to intervene and advise patient to stop fasting and start glycogen, to giving glucagon immediately. Okay, what are the symptoms which patient need to take care of? If he feels, the diabetic patient, if he feels dizziness, confusion, sweating, palpitation, severe weakness, at this time he need to check his glucose level. Okay, I have caution zone. If the blood glucose from 70 to 90, okay, I can tell the patient to continue fasting, but he must recheck within 1 hour. If it is less than 70, he need to stop, break his fast, and eating anything sweet. If it is more than 90, he can continue fasting. Okay, the other point related to the hydration status of the patient, dehydration. If the patient got persisting vomiting, diarrhea, or his urine output decreasing a lot, this will give high risk of thrombosis. And there is one incident I have seen by myself at the mosque one time. One patient got choked and he fell down unconsciousness. Uh, he got cardiac arrest. Later on, unfortunately, he died. It was in Ramadan and he was fasting. What's happening? The dehydration will cause, especially for the cardiac patient, will cause that the blood viscosity will be high. So it will increase the risk of platelet aggregation and clot formation for the patient. So if the patient is a chronic patient of angina or MI, so it will increase the risk of clotting formation. So it can, if it is not managed immediately, he can lead to death or cardiac, which means cardiac arrest. Okay, medication adjustment principles. Not all medication can be safely consolidated. We talked before about changing the time of medication, which means if the medication has been taken before Ramadan once daily, this is I don't have issue with this medication. He will continue the same. But I will choose either iftar or suhoor according to the type of medication. This we will know later. But if the medication is taken twice daily, BID, at this time I will shift the time to iftar and suhoor. But here there is one critical point I need to focus. Not all medication I can change its time easily from BID to the Ramadan time iftar and the suhoor. Why? Because some medication depend on the total daily dose. No matter exactly to be taken or to make the gap between the doses in exact time. Like for example, it must be, I'm talking about the BID medication, 2 times per day. It is not mandatory to be every 12 hours. Okay, the body responding according to the total daily dose. Okay, like for example, proton pump inhibitor medication, like painkiller medication, like some cardiac medication. Okay, which is taking BID. Yes, I need to make little gap, but not exact time every 12 hours. At this time, if I will advise the patient to take iftar and suhoor on its time. And also there is important point here that the patient who's taking medication BID, he must taking suhoor before Fajr. Some people in Ramadan to have enough sleeping time, they are skipping suhoor meal. And this is actually against our Islamic rule, because from Sunnah to taking suhoor, and also suhoor is an important meal because the body will depend on this meal all the fasting day. So before Fajr, he must taking suhoor, not before it. Not taking suhoor to 11, 12 p.m., then sleeping till Fajr. This is unacceptable for the patient who's taking medication BID, because I need more gap between the iftar dose and suhoor dose. Okay? But some medication need exact time every 12 hours, like antibiotic, like some antiepileptic. If the dosing time changes, maybe the therapeutic failure will happen. So because of this, I need to advise the patient either to change this regimen to once daily, or to discuss with his physician to be exempted from fasting if he has a serious condition. Some patient has acute infectious illness and he must be taking BID medication every 12 hours exactly. In this case, this patient can't fast if his condition is serious and there is no alternative to once daily regimen. But for and also for anti-epileptic, if the dose delayed or sorry coming before its due time, maybe the also the seizure will happen. So in this case, in some individualized medication, some specific medication has an exceptional rule. Because of this, I told you before at the beginning of the lecture, we are treating the patient individual patient with his own condition. The other thing, the anticoagulant, dehydration and renal function will affect the efficacy of anticoagulant. If the patient has decreased urine output or his renal function worsen, then the anticoagulant effect maybe will over therapeutic dose, which means bleeding risk can happen. So especially DWACs, direct to oral anticoagulant level affected by the dehydration status and renal function changes. So the patient who is taking anticoagulant, he need to, within Ramadan, he monitor renal function and adherence very closely. And it's advisable for this patient to make renal function every week to confirm that their renal function is okay, especially if the patient has kidney issue like chronic kidney disease, as we said before. High risk medication. As we classified before the high risk patient, now we are classified the high risk medication. We classified patient to high risk, moderate risk, and low risk. Now we will classify the medication according to also their risk. I have high risk medication, like which medication which I need to monitor closely and focus and tell advise the patient to take care of himself while taking those medication. Diabetic medication, diuretics. Diuretics, one of the most serious medication in the fasting. Psychiatric, especially lithium, because lithium, as we will take later, it is affected by, has narrow therapeutic index and also affected by the dehydration and affecting by the serum level of it. Antiepileptic medication, steroid medication, and immunosuppressant medication. Moderate risk like cardiovascular, ACE inhibitor or ARAPs, calcium channel blockers, beta blocker, anticoagulant, warfarin, direct oral anticoagulant, and painkiller, NSAIDs, and analgesics. Okay, for medication, I have some principle or an adjustment in Ramadan. I need to simplify this in 2 points. First point, timing. What does it mean? According to the type of medication, I will advise the patient to adjust it. If the medication cause like now, before I say general principle, like for example, if the medication is taking BID and there is a chance to make it once daily, it's okay. Shifting the time to iftar and suhoor, okay. But if the patient will take this medication once daily, which time I need to advise the patient to take his medication? Sorry, at iftar, after or before iftar or suhoor, according to the effect of this medication, the action of this medication. If the medication causes hypotension or hypoglycemia or dehydration or has thrombosis risk, so this medication must be taken after iftar, like diuretics. Diuretics can cause hypotension, can cause dehydration, and also has thrombosis risk because of dehydration, so must be taken after iftar. If the medication like beta blocker, like antihypertensive medication, can cause hypotension, also to be taken after iftar, can cause hypoglycemia, diabetic medication, and he need to take it once daily. So I will advise the patient to take it after iftar, not suhoor. If the medication affected by food, which means that its efficacy decreased by food, so I need to tell the patient to take it before iftar or before suhoor if I overcome the first point, of course, like PPI, proton pump inhibitor. It should be taken on empty stomach. So either I will tell the patient to take before iftar or be better before suhoor. If medication cause gastric upset like metformin, so I must tell the patient to take after iftar. If the medication need exact dosing interval like antibiotic or antiepileptic or immunosuppressant, so and this can't be achieved by fasting time as we discussed before, so if I have alternative to long acting, it will be better. If no, I need to discuss with his physician to be exempted from fasting. If medication can cause insomnia, so better to take at suhoor time, not sleeping on the daytime and he has working. Or opposite, it will cause dizziness. So better to take in after Isha prayer, not to be taken after iftar, then he will sleep in the prayer. Okay, second point, dose adjustment. While when I will modify or making the medication management in Ramadan, I will focus on 2 points: the timing of the dose and uh, the dosing itself. I will keep the dose same or decrease or increase. If the medication has narrow therapeutic level and needs serum monitoring like digoxin, like lithium, so I need to advise the patient to take enough water, minimum 3 liter if he doesn't have contraindication for this, and avoid dehydration to avoid toxicity and regular monitoring. And for this kind of medication, I need to advise patient also if he notice any abnormal symptoms to make like serum monitoring for this medication to avoid toxicity level. Also, I have other points. I need to adjust the dose based on the response. We talked before that some physiological changes happened during the body, within the inside the body because of during fasting time, and also some pharmacokinetic changes happen to the medication. So I have some medication will in Ramadan in fasting time will give me over therapeutic effect, and some of them can give under therapeutic effect. This according I will know this according to the response. For example, patient is taking antihypertensive medication and his blood pressure within more than 1-2 time it become very low or lower than normal. So I need to discuss with the physician or tell the patient discuss with his physician to decrease the dose or decrease the frequency. Either if he taken antihypertensive medication BID, for example, to make it once daily. But of course, in this point, I will not rely on one time, 2 time. No, I need to tell the patient to monitor blood pressure daily, and if he experienced hypotension more than 2-3 days, then I will tell him to discuss with his physician. Also, psychiatric medication. If the medication giving me more business effect or more insomnia, also antiepileptic, painkiller, diuretics. So any abnormal symptoms happen to the patient, I need to check the dosing, because while checking the guideline or the medication references, you will find most of medication have dosing range. Some few medication which has exact dosing, but most of medication have dosing range. So I can play within this dosing range according to the response of the patient, especially in fasting time in Ramadan. So the fasting will affect the efficacy of renally and hepatic eliminated medication as anticoagulant, as we discussed before. Some psychiatric, so consider dose modification if required. Now we will go for the group of medication according to the principles which we talked before. No need to memorize exactly the dose regimen of modification, but from these principles you need to discover what is the kind of modification you need to do. Metformin, diabetic medication, of course, the first hero of antidiabetic medication, the metformin. Metformin has low hypoglycemic risk, but it's a concern that he make GI upset at large doses. So what the adjustment need to be done? If the patient taking once daily XR, he will take this after iftar to avoid gastric upset. If he's taking it twice daily regimen, for example 2000 milligrams, then he will take 1000 after iftar, 1000 after suhoor. Okay, but if he's taking a regimen which can't be divided equally, for example 1500 per day, so I will give the larger doses like 1000 at iftar and the smaller dose 500 at suhoor, also because of my concern of GI upset. This is if the patient taking 3 times daily. Before Ramadan, he's taking, for example, 500 TID. So I will combine morning and afternoon dose, which is 1000 after iftar, then 500 at after suhoor. Sulfonylurea. Sulfonylurea has very high risk hypoglycemic, like Amaril. So, uh, my concern, I have one family of sulfonylurea, sorry, one generic, which is glibeniclamide. This glibeniclamide, it has higher hypoglycemic risk. So I better to avoid in the fasting time and shift to either glyclazide, MR, or glimepiride, which has lower hypoglycemic risk. If the patient taking once daily, I will make it after iftar to avoid hypoglycemic in fasting time if he's taking after suhoor, and try to reduce the dose 25 to 50% if good control. If the patient already is stable and his blood glucose is controlled, so I will try to reduce the dose according to response from 25 to 50%. And full dose I will take at iftar. And half dose if he's taking, for example, PID twice daily. So full dose I will take at iftar, and the half dose or modified dose. If I can't reduce, for example, to half, I can reduce 25, whatever. The reduced dose will be at suhoor. Okay, the other group, dipeptide peptide 4 uh, inhibitor. Sorry, dipeptide peptidase 4 inhibitor, like sitagliptin, vildagliptin, linagliptin. This family has very low hypoglycemic risk, so it is actually, if I can shift the patient from sulfonylurea group to this group, according, of course, to his condition, because not all patient can be general. I can't generalize this for all diabetic patients, but it is a preferred alternative for me for sulfonylurea. And also sodium glucose transportase inhibitor like empagliflozin and dapagliflozin. Also, this group has low hypoglycemic risk, but it has another risk, like can cause dehydration and hypotension and eglycemic DKA. So better to avoid this group, empagliflozin or dapagliflozin, in elderly patient or chronic kidney disease, or the patient who's taking already diuretics, okay, or the patient who's working in hot climates like some workers, okay, and better to take this at iftar with a proper hydration, as we said before. The medication like glucagon, like peptide one receptor agonist like liraglutide, semaglutide, dulaglutide. This group are not using only for as anti-diabetic medication. It is used also for obese patients. They are using to decrease weight. So this medication is safe, and also no dose adjustment needed, because mainly they are using once weekly. So and this injection, so no need to change anything. Insulin therapy like basal insulin, which is long-acting insulin like glargine, Litimer, Degludec. This has also hypoglycemic risk. So if the patient good control, I need to reduce the dose to 15 to 30 according to the, of course, the monitoring of the patient and his blood glucose level, and to be given at iftar or bedtime. So notice here, any medication has hypoglycemic risk, it will be taken after iftar, and if it is needed two times, the higher dose after iftar and the lower dose after suhoor. Premixed insulin like Humulin, Humalog, or Mixtard, 70 to 30 insulin. Better, I will use the morning dose, I will shift to iftar, and the evening dose in suhoor, I will reduce it to 25 to 50% according to, of course, the response to avoid hypoglycemia. Basal bolus regimen What basal bolus regimen? For treating the diabetic patient, I have some regimen if I will use insulin. The most updated regimen, which is called basal bolus, I will use long acting as basal, and the bolus I will use rapid or short acting insulin. Long acting as we take before glargine, detimer, degludec. This has hypoglycemic risk, so I will reduce the dose, okay, 15 to 30%. And the bolus insulin, either rapid insulin or short acting insulin like neutral, insulin neutral, and rapid acting like act rapid. I will take it with meal like iftar. I will take the usual dose, and suhoor I will reduce the dose of bolus insulin to 25 also to 50% according to the patient condition. And the lunch dose, if he's taking TID in the normal days before Ramadan, so this lunch dose I will omit, I will skip it. Okay, and the basal I will reduce as we said. Rapid acting analogs like aspart or lispro or glulizine, I will take it with meal like iftar and suhoor. Usual dose as we said, we'll take it normal and skip lunch dose, and the evening dose I will adjust it 25 to 50%. If the patient taking insulin pump, the basal rate where I will reduce the dose by 20 to 40 in the last 3-4 hours of fasting, and increase 0 to 30% early after iftar. Monitoring protocol. When I tell the patient need to monitor his blood glucose before suhoor and at the middle of the day and before iftar, okay, this is three regular blood glucose checking time. And at any time he feel any abnormal symptoms which we said before, dizziness, confusion, sweating, palpitation. Okay, the other non-diabetic medication, diuretics, either thiazide diuretics or loop diuretics, furosemide, hydrochlorothiazide. This it will increase the dehydration risk, and this is one of the high risk medication as we said. If the patient are taking two type of diuretics and his condition is stable, I will discuss with physician to make it one and one type of diuretics, or if he's taking BID to make it OD, and will advise the patient to taking to keep his hydration status, take a lot of water from iftar to suhoor, minimum 3 liter, as we said, if it's not contraindicated, to avoid the dehydration and avoid thrombosis risk. The ACE inhibitor or ARABs like lisinopril, enalapril, ramipril, losartan, valsartan, this medication also will worsening the renal function. So and can cause hypotension and dehydration. So it should be monitored, especially in elder patient. How monitored? As we said, weekly monitor for the renal function. Tell the patient to monitor his urine output. If it is decreased more, or he has feeling of hypotension symptoms like dizziness, also sweating, he need to check his blood pressure. And if it is continuous hypotension, he need to adjust tell the physician to adjust the dose. And if he's taking a BID, I will try to shift to long acting. Okay, anti-epileptic medication. Antiepileptic medication as antibiotic, as we said, I must to keep the interval as close as normal. For example, if he's taking in normal days before Ramadan every 12 hours, and I have a chance in the iftar time to keep the regimen every 10 hours, every 9 hours, then I hope it's okay. But if it is less than this, in some countries only the time from iftar to suhoor can be only 6 hours, 5 hours. So at this time he need to consult his physician to be exempted from fasting, or to search for alternative once daily. Avoid extended gap between doses, as we said, because the anti-epileptic, If the dose not taken on the proper time, maybe epilepsy can happen, seizure can happen at any time. Antiarrhythmic medication like amiodarone, like sotalol, whatever antiarrhythmic, switch to long acting once daily after iftar. Alpha blocker. Alpha blocker has a risk of posture hypotension, so better to taking before sleep at bedtime. Calcium channel blocker, I have two types. Dihydropyridine calcium channel blocker, which amlodipine, nifedipine, this taking after iftar or suhoor, whatever. But the non-dihydropyridine, like verapamil, diltiazem, better to taken after suhoor because it is has been affected by circadian effect, which affect the metabolism, which we said before. Digoxin, one of the medication which has narrow therapeutic level, so I need to keep the hydration status till the patient to avoid dehydration and also avoid toxicity due to hypokalemia. To keep his, I need to tell the patient keep his potassium level is normal, taking the food which has high potassium like banana, and also monitor the serum digoxin if he feel any abnormal symptoms. Antibiotics, like as we said, if it is once daily, I will take after iftar, BID, iftar and suhoor. If it is the gap will be as close as the normal days, and TID not ideal. So either I need to consider extended release alternative if it is possible. The lithium, like digoxin, high risk of toxicity because of dehydration, so I require monitoring or temporary discontinuation in some cases. A non-steroidal anti-inflammatory should be taken with food at iftar to reduce the gastric irritation and renal risk. Gastrointestinal medication like proton pump inhibitor should be taken 30 or 60 minutes before iftar. And this is the rule of all medication affected by food, also which need to be taken on empty stomach. If no any other concern to be, it will cause, this medication will cause if it is taken before suhoor, so better to take before suhoor because at iftar time, also after long time fasting, and I will tell the patient to start his iftar on medication, this is something in some patient unacceptable. So maybe he will not follow properly. So better to take his iftar normally, and before suhoor, before time of suhoor, already his iftar will be digested if he will not eat in between a lot of food. But before suhoor, so I have a chance to have condition or of empty stomach zone, then I can tell the patient to take his medication before suhoor if this medication will not cause any other side effect in the morning or daytime. Corticosteroid, actually, if it is taken at morning because it mimic natural cortisol peak. So if I take cortisone after iftar, so maybe it will cause insomnia. So better to keep steroid in suhoor time, at suhoor time. Statin, of course, as we know, is that liver makes cholesterol at night, so statin better to be taken before sleep. Either it can be taken after Isha before sleep, it's okay. Immunosuppressant also, there is important point here that immunosuppressant for the patient, for example, experience transplantation or some has some autoimmune disease. So the critical timing also, because if the time it changes, maybe rejection risk can happen from the body. So if all doses must be taken during the hours where the patient can eat or drink between iftar and suhoor. And for example, if the patient taking BID every 12 hour, I need to make the regimen in the Ramadan as close as much as closer to the normal regimen in other days. If it is TID and there is no alternative, the patient needs to discuss with his physician to be exempted from fasting or to search for another treatment alternative. Anticoagulant also no time it change, but taking with iftar meal and monitor. If patient taking warfarin, for example, I will monitor INR. Beta blocker, I will monitor heart rate, especially, and if the patient have fatigue is common with beta blocker. Once daily, it will taken after iftar, and twice daily, it will be splitted iftar and suhoor. Vitamin supplements, no issue to be taken iftar or suhoor, but iron must be taken with food. Actually, there is some like discussion between guideline. In some guideline, it will say that iron better to be taken on empty stomach, like up to date. But if the patient have some gastric upset or something, so he can take with food. Of course, food, يعني, but to avoid the calcium containing food, because calcium, it will affect the absorption of iron. And if patient taking calcium, it should be at night. And if he's taking both calcium and the iron, must be